Hello students. Welcome to Concepts of Care for Patients with Oral Cavity and Esophageal Conditions. This is part 2. We're going to start with esophageal conditions. This chapter is very important. We discussed already stomatitis, sialadenitis, premalignant conditions of the oral cavity, oral cancer, right? Candidiasis. So it's getting interesting. Esophageal conditions, um, especially gastroesophageal reflux disease, GERD. This is a topic that you need to master. Most of the reviews are considering this as the most important topic in this section. So GERD is the most common upper gastrointestinal disorder in the United States, occurs most often in middle-aged and older adults. GERD occurs as a result of backward flow of stomach contents into the esophagus, known as regurgitation. So when you have a back flow of stomach contents, it's considered regurgitation. GERD is the chronic and more serious condition that arises from persistent GERD, persistent gastroesophageal reflux, okay? Patients who are overweight or have obesity are at risk for GERD because excessive weight increases intra-abdominal pressure. We are going to watch a video about this because I want you to visualize exactly how the condition is developed.
When you eat, food passes from your mouth into your esophagus, a muscular tube that leads to your stomach. Your esophagus has a ring of muscle at the end, called the lower esophageal sphincter. It opens to let food into your stomach. Normally, it stays closed to prevent stomach contents from going back up into your esophagus. If the sphincter doesn't close all the way, gastroesophageal reflux, or GER, can happen. The weak or relaxed sphincter allows the contents of your stomach to reflux, or leak back into your esophagus. Acid in the stomach contents irritates your esophagus. This can cause a painful, burning feeling in your chest, called heartburn, or acid indigestion. It's common to have gastroesophageal reflux once in a while. However, if it happens more than twice a week for a few weeks, you may have a more serious condition called gastroesophageal reflux disease, also known as GERD. If left untreated, GERD can lead to complications over time. For example, you may develop esophagitis, where the lining of your esophagus becomes inflamed or irritated. Your esophagus may become too narrow, which is a condition called esophageal stricture. GERD may cause you to breathe stomach acid into your lungs. This can lead to respiratory problems such as asthma, chest congestion, hoarseness, wheezing, laryngitis, and pneumonia. GERD can also lead to a condition called Barrett's esophagus. In this condition, the cells lining your lower esophagus are replaced with cells similar to those in your intestine. This may increase your risk for developing cancer in your esophagus. Common causes of GERD include being pregnant or overweight, which puts pressure on your abdomen, smoking, certain medications, such as those that treat allergies, high blood pressure, and depression, and a hiatal hernia. A hiatal hernia is a condition where the upper part of your stomach moves up through an opening in your diaphragm. This makes it easier for stomach acid to come up into your esophagus. The most common symptom of GERD is heartburn. Other symptoms include nausea, problems swallowing, bad breath, hoarseness, sore throat, and bringing food back up, called regurgitation. To find out more about gastroesophageal reflux disease, talk to your healthcare provider.
Thank you so much. That was a very complete presentation of GERD, including other topics like hiatal hernia that we're going to discuss later. So right now we understand, right? The etiology and genetic risk. Reflux is generally sour or bitter. Although rare, a reflex salivary hypersecretion known as water brush can occur in response to reflux. So we need to understand that not when you're having that feeling of reflux, that can happen normally once or twice in a lifetime, or maybe once or twice in a week. That doesn't mean that you are having the gastroesophageal reflux disease. The disease is going to be diagnosed if you present, as the video explained, several weeks continuously, right? So you have 3-4 days in a week and you're having for several weeks. Now you may be having the condition, okay? And this is happening because we normally have this reflux depending on the food we are eating, right? If a stress was present at the moment of the intake of a meal, right? Maybe we were eating something that is kind of heavy. Maybe we are eating a citrus, a ceviche, for example, which is a Latin food full of citrus, right? And let's say at that moment you receive a bad news, so then you're going to start having reflux. However, if the condition is not repetitive, right, that could be a normal side effect of eating that citrus food, that citrus meal. But if you're having the condition repetitive for several weeks, that's when you are worried about GERD. Okay, water brush is different from regurgitation. The patient reports a sensation of fluid in the throat, but unlike with regurgitation, there is no bitter or sour taste. Patients who have a nasogastric tube have decreased esophageal sphincter function, right? The tube keeps the cardiac sphincter open and allows acidic contents from the stomach to enter the esophagus. So that's another thing that nurses will need to pay attention when the patient is at risk for this presentation due to the nasogastric tube. Pregnancy also, wearing tight belts or abdominal binders, bending over aside, all of those are factors that can contribute to GERD. Obstructive sleep apnea report frequent episodes of GERD also. Also, there is a strong genetic connection for GERD. During the process of healing, the body may substitute Barrett's epithelium, columnar epithelium, for the normal squamous self-epithelium of the lower esophagus. This becomes known as Barrett's esophagus. So the fact that there are cells that belongs to the stomach, and these cells are growing in the esophagus, that's very, very, very worrisome, because these cells are going to cause the risk for cancer in that area. It is premalignant, and it is associated with an increased risk for cancer in patients with prolonged GERD. So Barrett's epithelium is premalignant, but puts the patient at increased risk for cancer in patients with prolonged GERD. Uncontrolled esophageal reflux also increases the risk for other complications such as asthma, as the video mentioned, laryngitis, dental decay, and cardiac disease, as well as serious concern for hemorrhage and aspiration pneumonia. So everything is interrelated there. The population affected by GERD continues to get younger, formerly considered a disorder that affected infants or middle-aged and older adults. The proportion of people with GERD who are younger adults continues to rise. Think about young population that they are smoking, have alcohol habits, maybe drugs, they are asthmatic, right? So, patient-centered care, your health equity. Disparities increase when patients are not proficient in English and healthcare providers do not speak Spanish. That's one of the problems, right? Right now, with the immigration being so having people, immigrants from different countries, not only from Latin America, but also from Asian countries, from African countries in general, puts all these patients in risk for not understanding doctors' instruction or having access to healthcare providers in their language, right? So, okay. So I am going to go back to the table 46 that it was presented to us at the end of the previous recording. Factors contributing to decrease lower esophageal sphincter pressure: um, caffeinated beverages, coffee, tea, and soda, chocolate, nitrates, citrus foods, tomatoes and tomato products, alcohol, peppermint, spearmint, smoking, calcium channel blockers, anticholinergic drugs, your Parkinson, right? High levels of estrogen and progesterone, nasogastric tube placement. All these are factors contributing to decrease lower esophageal sphincter pressure. That's why reflux and regurgitation can happen. So this one here is a barium swallow, esophageal stricture, you can see over there. Okay, so health promotion and disease prevention. Adults with gastroesophageal reflux disease may initially be asymptomatic. Teach patients to engage in healthy eating habits that include consuming small, frequent meals and limiting intake of fried, fatty, and spicy foods and caffeine. Caffeine. Sitting upright for at least 1 hour after eating can promote proper digestion and reduce the risk of reflux, right? Question: the nurse has completed discharge teaching for a patient with Barrett's esophagus. Which of the following client statements require further nursing teaching? Select all that apply. I will be very careful when I eat or drink. Okay, so we are looking for the bad answer. I know that I am at a higher risk for cancer. I may experience stricture of the esophagus. I will now have a high sensitivity to acid foods, and I need to make sure to brush at least twice daily. And that's the wrong answer because we are talking about GERD, right? No oral health oral habits. Okay, so for GERD, you just need to double check or the risk factors, okay, related to that condition. Recognize cues, assessment history, ask the patient about a history of heartburn or atypical chest pain. Also asthma, morning hoarseness, or has coughing or wheezing, especially at night. Your physical assessment, you know that I want you to clarify that dyspepsia is stomach discomfort, right? Burping, nausea after eating, stomach fullness or bloating, upper abdominal pain and discomfort, stomach acid has inflamed the esophagus, and regurgitation is the sensation of acid backing up into the throat of the mouth. So let's review this again. So we have dyspnea, stomach discomfort, right? We have burping, we have nausea after eating, we have stomach fullness or bloating, upper abdominal pain and discomfort. Stomach acid has inflamed the esophagus, right? That's why it's causing upper abdominal pain. Regurgitation is the sensation of acid backing up into the throat or mouth. So don't get confused with the terminology, but you need to master the terminology. Dyspepsia, also known as indigestion, and regurgitation are the main symptoms of GERD. With severe GERD, the sensation generally occurs after each meal and lasts for 20 minutes to 2 hours. GERD after each meal and lasts for 20 minutes to 2 hours. Discomfort may worsen when the patient lies down because you are inviting the fluids, right, the reflux, to get into the esophageal area when the patient lies down. Drinking fluids, taking antacids, or maintaining an upright posture usually provides prompt relief. Somehow, by drinking fluids, you are rinsing, right, that area. So the key features: gastroesophageal reflux disease, you're going to see dyspepsia, regurgitation, water brush, which is hypersalivation, dental caries, severe cases, dysphagia, odynophagia, painful swallowing, globus, feeling of something in back of throat, which is sometimes is a permanent feeling. Some people report they have a permanent feeling of feeling something in the back of the throat. It's like the food is there, but I have finished my meal, but I feel I'm still having food there. Pharyngitis, coughing, chest pain, pyrosis is a heartburn, epigastric pain, belching. Okay, belching is burping to pass gas from the mouth. Make the difference between dysphagia, dyspepsia, belching, regurgitation, all those terms you need, because in the moment the patient is going to describe, right, the feeling, and you need to document the case in the software, in the medical records. Sometimes the medical records are going to give you the option, right, select what are the patient's symptoms. So you need to check if you are not sure of the description, okay, of the condition. How are you going to be checking those symptoms? And then the provider will read the report, and probably the patient is going to be treated in the wrong way. Other symptoms may include flatulence, bloating, and the symptoms typically worsen when the patient bends over. So that's another way to assess. You can ask the patient to bend over, strains, or lies down, as you ask the patient during the assessment process, when do you feel the symptoms are getting worse? And when you use your old cards, right? What is the location, the duration? What worsens the condition, what relieves the condition. If the indigestion is severe, the pain may be felt in the chest and may radiate to the neck, jaw, or back, mimicking a cardiac pain. Okay. Auscultate the patient's lungs feel, assessing for crackles, which can be an indication of associated aspiration. That's why I strongly recommend you to look for videos for lungs assessment and lung sounds. Where exactly do you position your stethoscope? I would love to do so, but I have to be doing that during lungs lecture, not in this lecture. Okay, find videos, practice with family members, and they are very nice mnemonic also to learn about lung sounds. Okay, what else? So, these symptoms typically worsen when the patient bends over, strains, or lies down. This is NCLEX alert. They are going to tell you a patient enters the clinic with such and such symptoms, and when the patient bends down, right, the symptoms worsen, this and that. They are going to give you a list of symptoms. Some of the patients, the questions in NCLEX, they are not going to state the diagnosis. They are going to give you the symptoms, and the question is going to be, based on the presentation, the nurse would suspect what condition? A, GERD. B, IBS, okay, irritable bowel syndrome. D, appendicitis, okay? So you need to master your presentation symptoms, so that's good to know. NCLEX. Psychosocial assessment. Patients may come to the emergency department fearing that they are having a myocardial infection. So yes, because the presentation, right, is going to be the heartburn in the chest and may radiate to the neck or back, mimicking cardiac pain. So in NCLEX question, you're gonna get that, and probably they are gonna give you a couple of symptoms that are related to GERD. So you need to know exactly, and probably in the options is gonna be a heart attack, right? Okay, GERD complication. Older adults are at risk for developing severe complications associated with GERD. Instead of the typical symptoms, this population experiences dysphagia, which is difficulty swallowing, vomiting, anorexia, anemia, cough, and respiratory concerns. Okay. Now, diagnostic assessment. Patients with classic GERD symptoms are diagnosed on the basis of clinical symptoms and history alone. That's why you need to observe and ask very careful for how many weeks are you having these symptoms, how many times a week, right? Those with atypical symptoms may benefit from upper endoscopy, also called esophageal gastroduodenoscopy. Okay, so let's watch a video to understand. I explained in class, esophageal gastroduodenoscopy means that the endoscope is going to enter through the esophagus, is going to observe the gastric area until the duodenum. That's why the name is esophageal gastroduodenoscopy. Let's watch this video.
Upper endoscopy is a test that looks inside the upper gastrointestinal or GI tract. The GI tract includes the esophagus, stomach, and duodenum, which is the first part of the small intestine. The test is also known as an esophageal gastroduodenoscopy, or EGD. It's done using a tool called an endoscope, which is a long, thin, flexible tube that has a light and a tiny camera. The test helps find problems such as ulcers, infections, or growths. It can show the causes of swallowing problems or dyspepsia, nausea and vomiting, acid reflux, bleeding, and abdominal pain. Before the procedure, you may have a physical exam, blood tests, or other kinds of tests. You'll be asked not to eat or drink for at least 8 hours before the procedure. Tell your healthcare provider about all the medicines and supplements you take, any allergies you have, and if you're pregnant or might be pregnant. Your healthcare provider will explain what happens during the procedure. He or she will also talk with you about any risks or complications that may occur. You'll be asked to sign a consent form that gives your healthcare provider permission to do the procedure. Read the form carefully and ask questions if anything is not clear. An upper endoscopy takes about 20 to 30 minutes. When it's time for your test, you may be given medicine to help you relax or sleep. This is called sedation. This medicine is usually given through an intravenous line, put in a vein in your arm or hand. Your throat might be numbed with a spray or liquid, and you'll be given a small plastic guard to protect your teeth. During the test, you lie on your left side, and the endoscope is placed in your mouth and moves down your throat. Air is used to expand the GI tract so your provider can see the lining more clearly. You may feel some pressure or discomfort from the air. The scope sends pictures of the GI tract to a video screen. Your provider looks at your esophagus, stomach, and duodenum for problems such as bleeding, inflammation, or growths. Using small tools inserted through channels in the endoscope, he or she can take small samples of tissue to send to a lab. This is called a biopsy. In some cases, your provider will remove small growths, the endoscope is then removed. After the test, you'll need to rest for about an hour to let the sedation wear off. This kind of medicine lasts for a while in the body, so you'll need a family member or friend to drive you home. Plan to take it easy for the rest of the day. If you had a biopsy, the results will be ready in about 7 days. Call your healthcare provider if you have any of the following: nausea and vomiting, vomiting blood, stomach pain that doesn't go away, black tarry or bloody stools, trouble swallowing, or fever. To learn about more procedures and screening, please subscribe and support us. In the next video, we will show the colonoscopy procedure, so stay tuned.
Okay, stay tuned for colonoscopy coming up next. Okay, in another chapter. Okay, so I want to say that after the reason why the patient is located on the left position is because most of the stomach is on the left upper quadrant. Okay, that's why the patient is positioned on the left side. Also, after the esophagogastroduodenoscopy (EGD), the patient may feel some sore throat. It's because the endoscope probably can irritate a little bit, and this is going to disappear in 1 day, no more than that. Okay, so those are the things that you also need to explain to the patient. Ambulatory esophageal, so that was the EGD. Now, another diagnostic assessment is the ambulatory esophageal pH monitoring. Is the most accurate method for diagnosis GERD. In this procedure, a transnasally placed catheter or wireless is transnasally, okay, capsule-like device is affixed to the distal esophageal mucosa. The patient is asked to keep a diary of activities and symptoms over 24 to 48 hours, depending on diagnostic method, and the pH is continuously monitored and reordered, right? Because they are checking the level of acidity. The level of acidity is going to tell you how much inflammation is that tissue at risk. Now, so the factors we need to worry about are the potential for compromised nutrition status due to dietary selection. That's why the diet is causing GERD. And then the acute pain due to reflux of organic gastric contents. So what are we gonna do to balancing nutrition? So the interventions are designed to optimize nutrition status, decrease symptom experience with GERD, and prevent complications. Non-surgical management. So we are going to have the nutrition therapy, lifestyle changes, and drug therapy. That's the protocol to start treating patients with GERD. Teach the patient that GERD is a chronic disorder that requires ongoing management. If you don't change your nutrition, this is going to be chronic. Ask about the patient's basic meal pattern and food preferences. Observe that I keep repeating everything is related to nutrition in all these different topics we've been talking about. We are talking about prevention, alcohol, tobacco, nutritional, viruses. In this case, it's about nutrition, okay? Coordinate with the registered dietitian nutrition. Teach the patient to limit or eliminate foods that decrease lower esophageal sphincter pressure. Foods that irritate inflamed tissue and cause heartburn, such as peppermint, chocolate. Yes, chocolate irritates the lower esophageal sphincter, decrease the pressure in the lower esophageal, and also inflame the tissue. Fatty foods, especially fried, your French fries, your potato chips that you love to buy, your snacks, right? Caffeine and carbonated beverages, your sparkling water. Professor, I don't like to drink spring water, so I drink sparkling water. Okay, so here you have irritation of the tissue. All these foods you need to avoid. Okay, the patient should also restrict spicy and acidic foods, orange juice, tomatoes, until esophageal healing occurs. Okay, so all of you who are getting your tomato pasta with a soda, right? And then you put some spices on it, right? So you're going to have problems with GERD. So one of the things that I wanted to mention is the inclusion of aloe vera, okay, that is going to heal the tissue. Okay, let's watch the video.
I'm back for another short video, this time on aloe vera. I had a question about it, my opinion on it, so let's just talk about it. So aloe is very nutrient dense. It has a lot of minerals, vitamins, and phytonutrients. It's primarily good for two things. One, sunburn or acne. Okay, so it's good for the skin. Also, it can help psoriasis in the scalp and digestion. Specifically, things like acid reflux or GERD, ulcers, and inflammation, as in Crohn's, IBS, celiac, things like that. And it's also really good for constipation because it can act as a laxative. You just want to make sure if you're getting aloe that you don't get the version with a lot of preservatives and chemicals. You want to get it as natural and as concentrated as possible. It also has antibacterial effects. It's good for your blood sugars, good for the hair, it's good for the immune system, and it has antifungal properties. But here's the thing. Anytime you take any remedy, I don't care what it is, you're treating the symptom. You're not really getting rid of the cause. So when you do research on aloe, it's mixed all over the place. Why? Because of the big variable on someone's diet. If your diet sucks because it's filled with garbage, this remedy will not work. And this is really the basic problem of medicine. It focuses on symptoms, not underlying causes. Now, I can see if you get sunburn, right? This will work great on your skin because sunburn is not a dietary deficiency of something. But just as a side note, if you do have a burn, one really good remedy is vitamin D. Now, normally you get vitamin D from the sun, but you don't want to get any more sun if you're burned. But if you take vitamin D, actually it clears up sunburn pretty quick. That's just a side note. But I would recommend aloe vera and a lot of other remedies only after you fixed your diet, okay?
Exactly.
Because chances are you probably won't even need this once you fix the diet. And I think people in general, especially in the medical field, do not connect the dots between all these symptoms that they're having and getting the diet corrected. If you're new to my channel and you don't know about keto and intermittent fasting, I put a link down below. Thanks for watching.
Thank you, Dr.
Hey, if you're
Bert.
liking this content, please subscribe now, and I will actually keep you updated on future videos.
Okay, that's something that I will recommend. I will strongly recommend to subscribe to Dr. Bird channel. Okay, has 11.5 million followers. He's an excellent reference for all this natural treatment. And as he mentioned, if you take aloe but you don't fix the diet, you can go to the gastroenterologist. The gastro will never recommend you aloe. Okay, the gastro is gonna bombard you with medications, but you need to fix the diet. Okay, probably the gastro will give you a brief list of recommendation of foods that you need to avoid, but you need to get deep into your healthy lifestyle habits. Okay, that's why I'm providing you with these videos and recommendations. Okay, let's continue. So, explain that large meals increase volume and pressure within the stomach and delay gastric emptying. That's why nurses, you need to know your map and you need to explain why. During your patient education session, you need to explain why you are giving distractions. if you are going to memorize your patient education, the patient is not going to absorb. You need to transfer your knowledge. Let the patient know why they need to do this. What is the rationale behind this, okay? The same way you learn your nursing concepts with rationale, the patient needs to know the rationale. Recommend eating 4 to 6 small meals each day rather than 3 large ones. Advise the patient to eat slowly and chew thoroughly to facilitate digestion and prevent eructation, belching, right? Teach patient to avoid eating at least 3 hours before going to bed because reflux episodes are most damaging at night. So what we said before? We said that the patient needs to be in a sitting position at least 1 hour after eating, right? So if the patient is going to eat before going to bed, that's going to cause a lot of reflux, okay? The risk for aspiration is increased if regurgitation occurs when the patient is lying down. Remind the patient to sleep prop up to promote gas exchange. This can be done by placing blocks under the head of the bed or by using a large wedge-style pillow instead of a standard pillow. That's good to know. Nursing intervention, patient education, NCLEX alert, okay? Teach that alcohol and tobacco should be avoided. So that green paragraph right there is the most important piece of information. Minimizing pain interventions, nursing care priorities, focus on teaching the patient about lifestyle modification that will improve comfort. Okay, lifestyle changes. In addition to nutrition modifications, discourage heavy lifting, right? Do you remember we talked about bending? Lifting, straining, and working in a position in which the patient bends at the abdomen. Encourage comfortable, non-restrictive clothing. Patients with obesity often have obstructive sleep apnea in addition to GERD. We spoke about this. Those who receive continuous positive airway pressure, your CPAP, treatment report improved sleeping and decreased episodes of reflux at night. Now, drug therapy. Some drugs lower the lower esophageal sphincter pressure and cause reflux. These include your oral contraceptives, anticholinergics, your sedative NSAIDs, nitrates, and calcium channel blocker. Drug therapy for GERD management includes 3 major types: antacids, histamine blockers, and proton pump inhibitor. Okay, and these drugs are used for peptic ulcer as well, which we are going to check in future chapters. So these medications, the functions are to inhibit gastric acid secretion, to accelerate gastric emptying, right? So you don't have the regurgitation or reflux, and to protect the gastric mucosa, right? So let's watch this video about the lower esophageal sphincter to reinforce our knowledge. It's a 1-minute video.
Gastroesophageal reflux disease, or GERD, is a condition that causes the burning sensation known as heartburn. When you swallow, food passes down your throat and through your esophagus or food tube to your stomach. A muscle called the lower esophageal sphincter controls the opening between the esophagus and the stomach. This muscle remains tightly closed except when you swallow food. When the sphincter fails to close, the acid-containing contents of the stomach can travel back up into the esophagus. This backward movement is called reflux. When stomach acid enters the lower part of the esophagus, it can produce a burning sensation commonly referred to as heartburn. Several factors might explain why this reflux action occurs. The most important are the following: the position of your body after eating. An upright posture helps prevent reflux. The size of the meal. Smaller meals reduce reflux. The nature of the foods you eat and drink. Certain substances that irritate the esophagus or weaken the sphincter can cause reflux.
Thank you so much. So Guys, I am spending a lot of time in this topic, as you see, because the book is requiring that you know this in depth. They are spending a lot of pages in this condition. So as I always tell you, the more time a book or the more pages you can see in reference to one topic means that it's important under the umbrella of healthcare, means that these conditions are causing expenses, huge expenses in healthcare, and you need to master this, because it's coming in NCLEX and you are going to see these conditions soon or later. It doesn't matter if you work in gastrointestinal, you can be working in a hospital and the patient can be admitted for a fracture and you're going to see this condition, or any other type. Okay, so you need to be familiarized. That's why I keep repeating videos that are reinforcing your concepts and your knowledge for you to understand this esophageal sphincter, for example, right? Let's go back to the drugs used for this condition. Your proton pump inhibitors, such as omeprazole or pantoprazole. Esomeprazole is known as Nexium. Okay, PPIs promote rapid tissue healing, but recurrence is common when the drug is stopped. So long-term use may mask reflux symptoms. Now, research has linked long-term PPI, long-term proton pump inhibitors, your esomeprazole, your Nexium use to increase risk for development of kidney, liver, and cardiovascular disease, dementia, GI tumors, difficulty absorbing nutrients, and susceptibility to respiratory and GI infections. So if you don't correct, if the patient does not correct the nutrition, the causative factor of GERD, the patient is going to become dependent of these medications and you see the complications. So the most important is, first of all, lose weight, have a flat abdomen, right, to lower the pressure in that area, and have proper nutrition. Okay, let's go to older adult health. So research has found that long-term use of proton pump inhibitors may increase the risk for hip fracture, especially in older adults. Okay, so that's another complication of PPI. Can interfere with calcium absorption and protein digestion, and therefore reduce available calcium to bone tissue, right? Decreased calcium makes bone more brittle and likely to fracture, especially as adults get older. That's an NCLEX alert. Okay, now endoscopy therapies, the Stretta procedure is one of the procedures to help with this condition, and we are going to watch the video of the Stretta procedure. Okay, so when they tell you the patient is going to go through this procedure, you know already what is your nursing intervention.
The lower esophageal sphincter, or LES, is a one-way valve that separates the esophagus from the stomach. When food or liquid is swallowed, the LES opens transiently to allow passage into the stomach. Otherwise, the sphincter remains closed to prevent stomach contents from flowing back up into the esophagus. However, for patients who suffer from reflux, the LES abnormally remains open, allowing stomach secretions and contents to reflux up into the esophagus, causing symptoms. Should medical and lifestyle management fail to resolve reflux symptoms, such patients may be a candidate for surgical intervention, which involves physically tightening the LES. The Nissen fundoplication or stomach wrap is the standard approach to surgically tighten the LES as shown here, and is performed using tiny instruments inserted through small abdominal incisions. However, there are procedures that can tighten the lower esophageal sphincter without any incisions. The method shown here is via a device utilizing radiofrequency called Stretta, made by ResTech. Under sedation, the Stretta device is introduced into the mouth under endoscopic guidance and threaded down to the LES region. The Stratus system then delivers low power, low temperature radiofrequency energy to the LES muscle. This non-ablative energy is delivered to multiple different sites, causing tissue remodeling, resulting in improved barrier function and fewer random relaxations that cause reflux symptoms. Radiofrequency energy has been shown to thicken the musculature and increase the size and amount of smooth muscle fibers in the treatment zone. The result is a measurable strengthening of the LES and a reduction in transient LES relaxations, but without causing stricture nor fibrosis.
Okay, there you go. So in this video we saw the Nissen procedure and the Stetra procedure, which is based on radio frequency. Okay, patients with obesity or those who have severe symptoms may not be candidates for this procedure. Again, patients with severe symptoms may not be candidates, or obesity may not be candidates for this straight up procedure, right? That we saw already is less complicated than the Nissen Fundo application that we are going to study later. Patients and family education. Postoperative instructions for patients having the straight-up procedure: remain on clear fluids for 24 hours after the procedure. After the first day, consume a soft diet. That's logic. Avoid NSAIDs, logic, and aspirin for 10 days. Common sense. Continue drug therapy as prescribed, usually proton pump inhibitors. Use liquid medications whenever possible. Contact the healthcare provider if you're having abdominal pain, bleeding, chest pain, dysphagia, blah, blah, blah. Okay, so that's common sense. Surgical management, usually indicated for patients who have not responded to medical treatment, meaning the patient got PPI, got other medications, and is not responding, have high volume reflux and intolerance or non-adherence to drug therapy. So the doctor prescribed many medications and there is no response. The patient is not getting better. Probably the patient is not following the right diet, right? In which case no medication is going to help. In some cases, it is also beneficial for patients with upper respiratory symptoms associated with GERD. So this is severe. It's not only the gastrointestinal, but also it's affecting the respiratory, the upper respiratory. So laparoscopy Nissen Fundo application is minimally invasive surgery and is a standard surgical approach for treatment of severe GERD. Information about this procedure can be found in the next session, hiatal hernia in the surgical management discussion. Okay, but we are going to review this because it's very important. This is the 10th video with almost the same information that we are reviewing, right? We review enough videos with the lower esophageal sphincter vision, but now we are going to see the surgery.
If you have gastroesophageal reflux disease, or GERD, your LES does not close properly, allowing acidic stomach contents to flow backward into your esophagus. At the bottom of the esophagus, food passes through a muscular valve called the lower esophageal sphincter, or LES, and into the stomach. The digestive juices secreted by the stomach are highly acidic. In the laparoscopic procedure, your surgeon will use instruments to detach the fundus of your stomach from its surroundings, wrap it around your lower esophagus, and stitch it into place. This wrap acts as a belt which tightens and strengthens the LES.
Okay, please understand that they are not cutting. Okay, there is not a resection. There is no cutting between the esophagus and the stomach for the Nissen Fundo application. What's happening is that they are taking a portion of the fundus of the stomach that I explained in the class what part is the fundus, and they are going to take that part without separating the stomach and the esophagus, and they are going to use that part. They are going to put it like an elastic, right? They are going to use that part and wrap it around the esophagus, and then they finish with stitches. Okay, so that surgery right there, if you think about it, not only is going to help with GERD, but also is minimizing the space of the stomach. Okay, so the patient is going to have more pressure in the lower esophageal sphincter, but it's kind of hell. Is kind of similar. It's going to have a very nice effect for those patients that are obese and they want to go through bariatric surgery. You understand what I mean? Because a good amount of the stomach is going to be wrapped around the lower esophageal sphincter. Okay, let's continue with that. So another one is the LINX reflux management system. The LINX can be effective for patients with typical GERD symptoms who have an abnormal pH study. Okay, only partially respond to daily PPI therapy and do not have a hiatal hernia or severe esophagitis. That's another approach. Teach patients who have had links to talk with a healthcare provider before having an MRI. Let's watch links. That's another approach, and you need to be familiarized with this.
When food and liquid are swallowed, they move down the esophagus and enter the stomach. The valve in the lower esophagus, the esophageal sphincter, then closes to prevent stomach contents from re-entering the esophagus. If the valve does not close all the way, or if it opens too often, food and liquid can rise back up into the esophagus. This condition, called acid reflux, can cause heartburn and other symptoms. The LINX device, a flexible circle of magnetic beads, is designed to keep the valve closed to prevent acid reflux. When you swallow, LINX expands so food and liquid can enter the stomach. The device then retracts to ensure that the valve closes completely and stays closed.
Okay, so that's another approach. They are going to put like a bracelet around the LES in order to control the opening and closure. There you go. So you have your Strata that works on with radio frequency waves, and you have your Nissen Fundo application, which uses part of the Fundo. That's why it's called Nissen Fundo application, which is going to be wrapped around the LES, lower esophageal sphincter. And then you have your links that uses a bracelet. Okay, here they are showing us pictures of hiatal hernia, and let me see. We are continuing with GERD, but let me describe a little bit this. You have your normal stomach here, the first picture on the left, and we have the diaphragm, right? Is at the level of the lower esophageal sphincter. Then we have the herniated portion of the stomach whenever the stomach goes up and invades the space of the esophagus. And then you have the herniated portion of the stomach called the paraesophageal rolling hiatal hernia. The one in the middle is called sliding because this can go back and forth, okay, depending on the stressors. So sometimes this portion of the stomach can go up and then goes down, right? But in this case is the hiatal hernia is going to be present all the way. When caring for a patient who has had LINX device insertion, we know the bracelet, emphasize the importance of telling each healthcare provider about this procedure. If an MRI is recommended, only certain patients with more recent LINX devices may be eligible to undergo scanning. Patients with older LINX devices which contain magnets should never undergo MRI scanning. So, the LINX devices that are done nowadays are made from material that are good for MRIs, okay? The LINX material that were done before, that's the older LINX devices, are not, they have magnets, so they are not good for MRIs. And the patient needs to tell, all the providers about this, okay? So that's good to know, NCLEX alert. Care coordination and transition management. Remind the patient to make appropriate dietary selection that enhances nutrition. Against nutrition is the base of everything, especially in this topic, GER, and decrease symptoms associated with GER. Adhere to drug therapy for patients with non-surgical GER. Teach about signs and symptoms of more serious complications such as esophageal structure and Barrett's esophagus. And we know already that Barrett's is a condition in which cells from the stomach invades the esophagus, right? Okay, so here we are going to start about hiatal hernia. We're going to stop this video here. I don't know you, but I am enjoying this chapter about gastrointestinal. It's one of my favorite topics. I really love everything related to gastrointestinal because everything starts, all the diseases and conditions starts in the gastrointestinal system. If we manage to control all the diseases, we get proper nutrition, we're going to be fine. The stomach, the gastrointestinal, is the second brain in our body. The gastrointestinal has the most amount of nerves in our body. Okay, that's why when we feel love, we feel it in the abdominal area. When we are stressed, we feel it in the abdominal area. When we are scared, we have problems with bowel movements. It's the gastrointestinal, the second brain in our body. So when we come back, we are going to talk about hiatal hernia, okay? And more information to come. Thank you. Stay tuned.